from a layman term or in simple terms, how do you differentiate, disorders which we see as Alzheimer's, Parkinson, and dementia?
So that's obviously the most basic thing that we need to know, because how do you differentiate these three common conditions to speak about in layman's terms? Parkinson's disease, all the three are neurodegenerative diseases. When I say neurodegenerative diseases,
what does that engineering the mind mean?
How there was a collaboration between engineers and physicists and basic scientists to get to the level that we have achieved today.
What fascinated you to get into the neurosurgery and DNB?
If you see in anatomy, all of us had a challenge when it came to the nervous system, which includes the brain and the spinal cord. But somehow I was always fascinated.
There were estimated 771,000 people living with Parkinson's and 45,000 deaths. Today, maybe because of the awareness and also a lot of tests, we are able to identify more patients. That's why the rise is. How do you see that in your practice, right?
So nowadays, definitely the awareness is improved. As you get older, there is going to be some problem in the brain. Not everybody is lucky that you have a very, very good functioning brain throughout your life till 90, 80. So that is one common reason why we are seeing more and more conditions of Parkinson's.
You did India's first high cervical spinal cord stimulation case you performed for Parkinson Plus on a 65-year-old patient from France.
Means I put an electrode near the neck. So that is the cervical spinal cord. So what happens in that is there is this flow of electricity that is coming from the brain, and that gets very concentrated near the upper part of the spinal cord and then goes down into the spinal cord to the rest of the body. So that is the area cervical spine, which has a lot of concentrated activity of electrical activity, which is going up and down the brain. So when we did this stimulation, what happened is all our hand movements became much more freer, our gait became significantly better, our urinary disturbance became significantly better. It's not like she became normal, but compared to what she was in a wheelchair, unable to move around. Now she's able to move around with one guy's support. Her urinary symptoms completely improved. So that was a kind of breakthrough.
And then during the surgery, you will hear all the brain neuron interactions throughout the surgery, right? I think there are some live videos in the YouTube too about the whole DBS, and it's amazing to look at the kind of.
We record we record, like you said, the activity of the neurons. It's called microelectrode recording. So the electrodes are so fine that we can actually record from a single neuron. So this is a very brilliantly done study. They did an autopsy study of drivers who had died before the Google Maps and all that was arrived, because these brains were preserved in their laboratories. And they found that there is this very specific area in the brain called the hippocampus. Okay, so that area was very, very well developed and very big area in the guys who were not using the maps or the Google Maps. Once the guys started using the maps, that area started to shrink in the brain. We are seeing patients who don't do any activity, who are very laid back, and can tend to see Parkinson's at an earlier age. So there is no one specific reason. If you ask me, point this out, Dr. Raghuram, that this is the cause. We don't have like that. We know that smoking causes lung cancer, right? So there is nothing like smoking or anything which can cause Parkinson's. Please don't attribute everything to being old. Come back, go to your family physician, or first check up with your regular doctor. And if he's not able to solve it, go to a specialist and reach out to them.
When do you think the functional conditions actually require a surgery? Right?
Only if it is an organic cause, there is a definitive abnormality, the EG, there is hyperelectrical activity, then only you need a intervention. Thank you, Naga. Thank you so much for having me on your podcast. I know it's a very popular podcast, and many of them, I keep seeing all your posts on LinkedIn. So it's a pleasure. Yeah, it's going to be an interesting discussion, I think. So let's move forward. Yeah.
Hello and welcome to another episode of Cafe Log with Naga, where we bring people, passion, and profession that shapes the world around us. Today, we are honored to join by Dr. Raghuram G, the Additional Director of Neurosurgery at Fortis Hospitals Bengaluru. With over 20 years of surgical excellence, Dr. Raghuram is known across India for his mastery in both brain and spine neurosurgery. He graduated with his MBBS in 2000 from MS Ramaya Medical College and went on to earn his DNB in neurosurgery from Jaslok Hospital, Mumbai in 2009. Followed by a prestigious fellowship in stereotactic and functional neurosurgery at Tokyo Medical University in 2011. Over his career, Dr. Raghuram has performed thousands of complex surgeries, ranging from minimally invasive technique and skull-based procedures for functional neurosurgery like deep brain stimulation for Parkinson's and epilepsy, even pioneering Karnataka's first targeted DBS surgery for drug resistant epilepsy in 2025. He is also an accomplished spinal surgeon performing microdiscectomies, laminectomies, spinal fusions, kyphoplasty, and motion preserving disc replacement surgeries. While contributing to medical education, CME workshops, and lot of international neurosurgical forums, Dr. Raghuram has been constantly creating awareness in social media for epilepsy and other neurological disorders. Today, he brings us rare insight into the evolution of neurosurgery in India and how technology and compassion intersect in the operating room. Without further ado, let's welcome Dr. Raghuram to our show. Hello. It's an honor, Doctor, to welcome you to my show, Cafe Log with Naga. And thank you so much for taking time on a weekend and trying to spend time with me. It's I mean, I think brain and spine is an important health topic to talk about. I think I'm fascinated about uh, especially what happens in the brain. And I mean, none other than you could do justice to such powerful conversation. I mean, being a leading neurosurgeon in India and doing a lot of innovations and bringing technology breakthrough into the brain surgery. So I wanted to have this conversation with you. So it's absolutely a pleasure and honor to have you, Doctor.
Thank you, Naga. Thank you so much for having me on your podcast. I know it's a very popular podcast, and many of them I keep seeing all your posts on LinkedIn. So it's a pleasure. Yeah, it's going to be an interesting discussion, I think. So let's move forward. Yeah.
All right. So before I get to my questions on your expertise and specialty on the neuro surgeries and what happens inside the brain, but I want to get your journey for the audience. Like, what fascinated you to get into the neurosurgery and and DNB? After you finished your MBBS, maybe give me your professional journey and how did you start neuro as a practice, and what made you take up, be it a mentor or something you looked at and probably that created curiosity. So definitely curious to learn and know that. Let's start from
Yeah.
there.
Yeah, sure. So I did my undergraduate from Bangalore and from MS Ramaya, and then I did my post graduations from Bombay, both in Jaslok and then in Sion Lokmanya Tilak Municipal Medical College. So when I was in MBBS, I was quite fascinated, to say frankly, even during the first year itself, when we started learning about the anatomy of the brain. Actually, if you see in anatomy, all of us had a challenge when it came to the nervous system, which includes the brain and the spinal cord. So we would
Yep.
always keep thinking, oh, this is the most difficult part, and we don't want to do anything with it and try and mug it and finish it as fast as possible. But somehow I was always fascinated. And at the same time, we also learn what is called as physiology, right? Which means how each particular organ in the body works, like whether it's the heart, the liver, the kidney, or the brain. So I had a very, very, very interesting neurophysiology professor, Professor Gautam. So he was a big influence. He used to, even at that time, this is way back in 94, 95 in India, and then he used to do a lot of research on hot water epilepsy and other things. So he kind of stimulated me more and more to look towards the brain. And so you can say that probably that was the beginning of my interest in neurosurgery and things related to the brain. Obviously, as you go through the clinical rotation, you kind of see all the specialties that is there in the MBBS level, and then you kind of have to get a chance to rotate in different departments during your internship. So what I did during my internship, we have something called electives, and I chose neurosurgery as an elective. So we had very, very good professors like Professor Krishna, Dr. Balaji Pai, and Professor Ravi Varma, and all that in our unit. And they were all extremely, it was like real absolute magic kind of a things for us to see that how these patients and how they operated on the brain and how they got better after that. And even though it was in the early times, they were still doing a lot of advanced work, and looking at all that and the kind of the results and the effort that they put in, it kind of drew me more towards neurosurgery. So those are the things which I can even now remember that, which made me choose neurosurgery. And like you said, after I finished my MBBS, I went on to do neurosurgery in Bombay. So it was a challenge in the beginning to move to a different city, especially for a South Indian to go to Mumbai. But we had a lot of good friends, and people really mentored us. We had a few people in Bombay who would guide us. So that way, when I went to Bombay again, I had the lucky and opportunity to learn from the doyens in neurosurgery in Bombay. So they also
Yeah.
had a big influence in me, kind of continuing the course, even though it's a long 6-year course. We managed to, gain that much of interest and value to the whole course by these senior teachers.
Okay. Yeah, that's a very powerful journey. I said, I think it's more probably sometimes it's a calling. Probably I
Correct.
know it's a mysterious. So brain, when you think about it, it's more mysterious because a lot of times the mystery is when you don't know much. So and then it's intimidating too, right? To get to know more. So unless you are a neurosurgeon or somebody who does look at imaging of brain, you will not have an understanding of it because the rest of the parts, especially if you're hurt in hand or your arm or anywhere, you can actually see it. Probably at least the naked eye can understand, but brain is one part which is so important for the entire function of the human body, and it's a fascinating practice to be in, and I can see the passion from you.
Yeah.
um, so I mean, you talked about the medical school and early training and where why you were interested in. So again, just to understand, right? I listened to your TED talk as well as I know you've put a very strong message, or probably a word, which is metamorphosis, the engineering
Yes.
the mind. So I really
Correct.
liked I really liked the term engineering the mind. So maybe I wanted to get directly from you on what does that engineering the mind means, and the brain behind that.
Yeah. So that's what I'm saying. Like you said, it was always a mystery, right? Even today, we really don't know so many things about the brain, even though we have progressed a lot from what it was. So that was my talk about metamorphosis when I spoke
Hmm.
on my TED talk to the engineering students. So that's what I mean, like how there was a collaboration between engineers and physicists and basic scientists to get to the level that we have achieved today. So that was what
Hmm.
was the main engineering behind the whole thing. When I'm saying that when you have to engineer the mind, I'm sure we will discuss that in the subsequent talks.
Yes.
We can see that how much advancement in technology, how much advancement in engineering that has happened in terms of imaging and other things that help neurosurgeons or neurologists to diagnose conditions in the brain, that we have been able to reach a state where we can do many things by modulating the electrical activity of the brain. So it's really a very, very fascinating subject, and very fascinating things to do right at this time, especially to practice neurosurgery. We all have
Yeah.
really doing amazing things, and I'm lucky to be part of it in terms of functional neurosurgery, which kind of uses the state of the art, high tech stuff that is available to do these very, very precise and very, very rewarding neurosurgical procedures.
True. I think it. So I think the approach what at least you have taken, and probably you're putting out a message, is very, very powerful or compelling, because it's not as a practice, it's only more medical oriented, but how do you blend technology advancements into this and help much more patients, and cure the very, I mean, chronic diseases like epilepsy, or even Parkinson's, or other neuro functional disorders, right? So it's a fascinating time to be with the technology interventions, and I know you are pioneering that with a lot of breakthrough surgeries in Bangalore. So I'll talk about it in the coming discussions. But to start with, I want to start because I know you're passionate practice. While in neurosurgery, there are multiple neuro functional disorders, and kind of I mean, if I look at it, neurodegenerative diseases, which is prevalent at this age in the world. um, Parkinson's has been one of the, probably prevalent, or not many would. I mean, I was, when I was trying to even do the research, because I thought the prevalent of the disease is more in the West, but I now also see that much more, probably it's unknowingly. But today, with the awareness, there is a lot more, people are actually coming forward and actually getting the treatment for Parkinson in India, or, in the developing countries as well. But that was not the understanding, right? Parkinson's was more of a West, or not really talked about. So what was your motivation in, taking up that primarily, and because you see that the case is more rising without more technology advancements in that area? That's my question. And before we go there, I want, from a layman term, or in simple terms, how do you differentiate? Because the three common, um, disorders which we see is Alzheimer's, Parkinson, and dementia. So, I mean, probably Alzheimer's and Parkinson's is more of uh, one of the area in dementia. Or, I mean, I just want to understand the difference from an audience perspective, right? How do you see this?
Yeah. So that's obviously the most basic thing that we need to know, because how do you differentiate these three common conditions to speak about in layman's terms? Parkinson's
Mhm.
disease, all the three are neurodegenerative diseases. When I say neurodegenerative diseases, what does it mean? Does this happen only in old people? Not necessarily.
Mm.
When I'm saying neurodegenerative, we know that there are some changes or degeneration that is happening within the brain, which leads to these conditions. That's why we call them
Right.
neurodegenerative conditions. The first thing is Parkinson's. In Parkinson's, we know that there is a deficiency of production of a very important chemical in the brain. That's called the dopamine. So that is the
Dopamine.
degeneration that is happening in Parkinson's. So we all know that the brain works through electrical circuits. So they're very, very important different circuits in multiple areas of the brain. And this dopamine is a very essential component in what is called as the movement circuit. That means how you move, how you act, how you walk, how you speak. That important circuit, this dopamine is an important chemical which is required. So what happens in patients with Parkinson's is when this thing becomes deficient, they become very slow. They start having tremors, or their hands keep shaking, which is
Mm.
because of, again, this dopamine deficiency leading to an abnormal firing of different neurons. Our brain is so beautifully wired that even to speak or even to do a specific movement, there is a multiple area that gets activated, and in a very, very orderly fashion. So whenever this orderly fashion is disturbed because of a deficiency of a particular neurochemical in the brain, that's why when you start seeing Parkinson's disease. So that's the most commonest symptom that you would see in a patient with Parkinson's disease, is that they become slow, you know,
Mm.
and many of them attribute to age. Like you said, is it because of an aging population? Yes, because now the life expectancy, even in a country like India, has significantly improved. We have achieved much more higher than what we started when at 1947 when we were independent. So that way, the awareness also has improved, and the longevity itself can contribute to development of neurodegenerative conditions, right? So as you get older, there is going to be some problem in the brain. Not everybody is lucky that you have a very, very good functioning brain throughout your life till 90, 80. So that is one common reason why we are seeing more and more conditions of Parkinson's. There are also certain genetic changes that happens. So once the Parkinson's disease is diagnosed, we know that there is an abnormal mutation of a gene called Parkin gene. So in
Mm.
some patients or in some families, that can happen even younger. So I have even treated a 35-year-old patient with Parkinson's. So it
Oh.
doesn't mean that Parkinson can come only in the late 60s or 70s. So that is the first thing about Parkinson's. And the most important differentiating feature, coming to your question about Parkinson's and dementia, is in Parkinson's patient, there is no memory disturbance at all.
Mm.
Usually they have very, very good memory. There are a group of syndromes or conditions which mimic Parkinson's. In those conditions, you can have memory disturbance. So if I am treating a patient, one of the commonest questions or one of the most important questions that I ask is your memory disturbed? So in
Mm.
Parkinson's, usually you won't see any memory disturbance. The second thing is dementia. What is dementia? Dementia is, again, as you age, there are some atrophy or the brain starts to shrink. And if it affects the memory circuit, then you start developing memory disturbance. That is dementia. The one of the differentiating or one of the most severe forms of dementia is Alzheimer's dementia.
Alzheimer.
So Alzheimer's can also happen sometimes in your late 55s or 60. Usually it sets in much later. But again, in Alzheimer's, we see definitive degenerative change within the brain. where there are abnormal deposits within the brain. So that's how we know that Alzheimer's is also a progressive dementia disease. But from the basic dementia, Alzheimer's dementia is more severe. That means basic dementia may be that the patient doesn't remember what he ate. Sometimes he may get lost. Whereas in Alzheimer's, they forget their own family members. They get lost within the house. And if they go out, they get completely lost. So that is the more severe form of dementia is Alzheimer's dementia.
So the Parkinson's is more, I mean, if I have to put it in one sentence, it's more of something which is actually impacting the hardware, but then the dementia and Alzheimer is more of the software.
Yeah. So it's
Within
more
the,
easier to put Parkinson is more of a movement disorder problem rather
okay.
than a memory disturbance, whereas dementia and
May,
Parkinson's are primarily memory disturbance.
it's going to impact your cognitive skills
Exactly. Whereas
as well.
Parkinson is going to impact your movement, your walking, all these
Walking.
ambulatory activities that you do. That's why it's part of the movement disorder.
Yeah, I think what I've also saw a progressive Parkinson's disease person. His mind is still active, but the problem is he's not
Exactly.
able to do things in the pace what he wanted, or probably there's. It's very disturbing to actually stay when you know that you can do, but you're not able to physically do that. It's a very difficult situation to be. So, but the disease connections between Alzheimer and Parkinson. So, I know you talked about Alzheimer and the deposits. So, I mean, what I understood from the research and also what the articles and the doctors. I mean, Dr. Ray Dorsey, who's the neurosurgeon in the Rochester here in New York, he says that Parkinson's, after so many years of research, has been understood that at least it is not more of a genetic. It is not a genetically inherited disease, but it is more environmental and probably lifestyle as well. That's the major. So they have done research with so many, almost 10,000 Parkinson's patients, out of which were 12.4% of them only contributed or probably had a genetic inheritance, but then the remaining 87% had an impact of environmental health issues. So do you see in India as well? Is it, as you said, you're 35-year-old or probably, so any known causes you have seen from the pattern of people you have or anything which you want to share?
There are only two things, like what the New York study says. We also have a very pioneering study, maybe you wouldn't get a chance to look at it, is from NIMANS, okay,
Okay.
and from Bombay, where they have studied it in our group of Parsi patients, okay.
Hmm.
So in this group, especially in a subgroup of Parsi patients, we see a genetic form of transmission of Parkinson's disease. It's
Hmm.
very well established and recognized all over the world. Okay, so that's the one thing. In sometimes you may see young onset Parkinson's patients.
Hmm.
Okay, there are this particular group of people who do get it, and like I told you, once they get Parkinson's, many a times you can see a genetic study. Right
Hmm.
now, as I speak, we are all part of a big genetic study in Parkinson's where we are trying to use multiple things like a blood or a saliva to kind of analyze, because our genetic technology has improved so much.
So
Now
much.
we are able to identify things which we were not able to do previously. So that is one part about the genetics. The second part, obviously, is environmental. We really don't know what are all the specific pollutants or things that
Hmm.
can lead to Parkinson's, but inactivity, having a very sedentary lifestyle, not doing any form of exercise, all can probably aggravate or maybe make you get Parkinson's at an younger age. So that we are seeing patients who don't do any activity or very laid back, and can tend to see Parkinson's at an earlier age. So there is no one specific reason. If you ask me, point this out,
Hmm.
Dr. Raghuram, that this is the cause. We don't have like that.
I don't
Like
have.
we know that smoking causes lung cancer, right? So there is nothing like smoking or anything which can cause Parkinson's. We know there are a lot of
Hmm.
environmental factor that happens, and we really, as of today, we don't have any clue as to why in one particular patient that leads to Parkinson's or
Hmm.
not in the other.
But I think one when in I think the recent conversation which I listened to as well from Dr. Ray or says he actually attributes that after studying for almost 35 years of people, one environmental factor is they say Parkinson is kind of attributed to more of a man-made in these with lifestyle complications, but toxicity, especially somebody who is closer to a golf course within 1 kilometer. So they've done a research and they said because the golf course uses almost 50% of pesticides to actually right, and then it is evaporated in the environment, so in constant inhalation of that, they've seen a group of study of that, and also the TCE, which is actually in the trichloroethylene in the dry cleaning. So if you're actually closer to a dry cleaning area or your house is above, it actually evaporates in the and anybody who has been through be a plumber or anywhere in the use that as a long-term association, or probably after 30 years they seem to develop Parkinson's is what he's concluding. Yeah,
Yeah,
there's a lot
but that's what
talk.
I'm saying. It's very
Yeah.
anecdotal, Naga. I don't think
Hmm.
you can really kind of
Say
give
anything.
credence to that. It's maybe only
Hmm.
his study. I mean, I'm doing Parkinson's disease and neurosurgery and doing for almost 25 years now. We don't attribute it to somebody who is staying in the golf course. All the big shots, inverted comma, want their houses to be close to golf course so that they can play golf all the time. So if it was true, Naga, then none of them, including the presidents and the other big shots, would not be near a golf course.
Not been, yeah.
So I think it's
It,
far
it's
fetched.
not proven.
Exactly.
Yeah.
So I think it's completely not right for us to send that kind of a message. It's too far fetched. There is no scientific evidence as of today when I'm speaking to you that you stay close to a golf course, you have a higher incidence of Parkinson's. I think that is a period kind of a full stop statement. I don't think we should even discuss that, and it's not fair to people who are listening to it that we give them that kind of an idea. Nobody who stays close to the dry cleaning shop gets Parkinson's. There are toxins, yes. We have a laboratory model of a pesticide kind of a thing which we give the rats, which is a very MPTP it is called. It is a very, very standard, scientifically approved model for studying Parkinson's disease, because we have to create Parkinson's. It's a human disease. It's not a disease which comes in animals. So when we do study, we inject this chemical into the rats. They get Parkinsonian and Parkinson symptoms, and then we try treatments. When they do the trials, they try that. So that kind of a toxins, definitely any toxin for that matter, can produce various kinds of disease. But I don't think we should kind of say that you stay close to a golf course, you have a higher instance. That's still not. It's very anecdotal. Maybe in his research he found it. I'm not denying that, but that's not something that is proved across.
Okay. Yeah. No, I mean the research is actually very constant, evolving area. So based on the sampling and how you study it, it actually
Exactly.
varies. So.
No, if it is something like I told you, smoking, right? So smoking, there is no doubt. Eating pan or chewing pan, there is no doubt. It happens across. So it's not something that is still validated enough. So in science, we have something called class 1, class 2, class 3, class 4 evidence, and then an anecdotal evidence. So it is nowhere near what is called as a class 1 evidence.
And so my next question is, how do you decide between medication management and surgery, like DBS for Parkinson's patients, right? So how and so is it everybody? Is it more of a progressive stage? So then we decide to go into more of a DBS or a surgery, uh,
Correct.
or when do you decide? Especially, I mean, how long a patient can manage with medical medications, right? And then before they decide to go into something like DBS.
Correct. So that's a very, very important question, and for a lot of people to understand when they should go ahead and kind of take this decision to go for a DBS surgery. So usually the DBS or the Parkinson's disease patients are primarily treated by neurologists, and the first goal of treatment is to replace the dopamine, right? So we very clearly know that there is a deficiency of dopamine in the brain, which has caused this. Is there a scan or something which can tell us? Now there is some increasing use of what is called as a PET scan. We inject the dopamine into the patient's body and then do what is called as a positron emission tomography or a PET scan, in which these areas in the brain, which is called as the substantia nigra, where the dopamine is concentrated, do
Yes.
not light up. So then we know that there is a deficiency. So that way we diagnose. So the first line of treatment is obviously replacing the dopamine. So as soon as you're diagnosed with Parkinson's, definitely we don't do surgery. There is no question of offering surgery as the first kind of a therapy. Usually, what happens in Parkinson's disease, since it's a progressive neurodegenerative disease, over a period of time, usually that is about 3 to 4 years, they start developing more and more symptoms in spite of being on medications. So that is the time when we start thinking about deep brain stimulation. So that's the time when we start talking to the patient. See, now we are giving you almost 5, 6, 7 doses of these medicines. We have added one more medicine. We have added the third medicine. Still, you are not getting the benefit. you're still having only the effect for 1 or 2 hours, that's the time we start thinking about surgery. And like I already told you, if we find anything during this 3 to 4 years which suggests that this is not only Parkinson's but the syndrome which mimics Parkinson's, like I told you, they're all called Parkinson plus. So if
Plus,
it is a condition which is like Parkinson's plus, then you automatically don't qualify for any kind of surgical intervention. So only if it's an idiopathic Parkinson's and you have a consistent response to the levodopa that you are taking, that is the time that we will say that, okay, now your medicine is not working. We have in scientific terms what is called as motor fluctuations. So when the patient is having a good effect, it's called on. And if the patient is not having an effect and not able to walk, starts having severe tremor, it's called off. So when this on becomes less and off becomes more, that is the time we start thinking of deep brain stimulation.
yeah, when you say on and off, I think I've seen this a patient talking about, when the electrodes are that, they switch off, and how how the
Yes.
body
So
behaves, and then when it
that's a
switch
different
on,
on and off of the
yeah,
pacemaker. Yeah. Yeah.
yes.
So this is more.
So
This is a very classical scientific term that when the
yeah,
patient has a good effect of the medicine and is able to do his activities, it's called an on. And if even if the patient is on the medicine but not able to move, is having severe tremors or
severe.
shaking of the hand, yeah, that is called as the off period.
Okay. So when Parkinson's, this dopamine comes into picture, right? So I think dopamine is a very widely used term these days in terms of
Exactly.
anything anything more of
Yeah.
dopamine effect, and everybody starts talking about dopamine, but ideally, if it doesn't work as it's supposed to be, then it is actually a very
Correct.
disastrous situation you have to be. So
Yeah.
how do you control the dopamine effect to an as needed, as and not just continuously stimulate is also an important. Do you see this in this generation with the kind of use of technology, or probably the kind of constantly stimulating brain with a lot of content and consumption of media and through mobile technology? So do you see it is actually going to hurt in future long term from a brain and neurodegenerative diseases standpoint, from a
Very true. Very true. So it's a very, very interesting topic that is being very widely researched all over the world in multiple
yeah.
places. So definitely the use of gadgets and mobiles have definitely have an effect on the brain. Like previously, I think when we were small kids, there were no mobile, and if you ask us to remember 10 phone numbers or 12
Yes.
phone numbers,
Yeah.
we would just rattle them, right? We wouldn't even blink an eye. We would be able to remember our numbers. Now it's
Yes.
even very difficult even to remember our own spouse mobile number because you're so used to just having the phone, just
Dialing
clicking
the.
on it and calling everybody. Exactly. So that is one
Yeah.
thing. So definitely your brain is not working as much as it was working previously.
Mm.
So just to take a little bit of deviation, there was a very, very interesting study done by the Oxford group in UK. The London taxi drivers, apparently their main important thing to qualify for taxi drivers was that they had to know all the roads in London very, very thoroughly. So
Yes.
that was a
Yeah.
proper test that they had to do before they got the driver's license for taxi. So they did a study on post-mortem study. So this is a very brilliantly done study. They did an autopsy study of drivers who had died before the Google Maps and all that was arrived, because these brains were preserved in their laboratories,
Mm.
and they found that there is this very specific area in the brain called the hippocampus. Okay, so that area was very, very well developed and very big area in the guys who were not using the maps or the Google Maps. Once the guys started using the maps, that area started to shrink in the brain. So you can see that how disuse atrophy is, what is the scientific term you use. So
Yeah.
like that, now we are seeing in multiple parts of the brain, like the brain which uses max, right? So there is an area in the brain which is called as the parietal lobule, which is important for doing all your max work and coordination and all that. Now with the use of more and more mobiles, you are seeing that area is stop
It
functioning.
stopped
And the
functioning.
frontal lobe, which is the one which is controlling your emotion, your urge, your behavior, that is starting to become more and more bigger. The limbic system is starting to become bigger. So definitely
I
there is a
have this
correlation.
here.
Yeah, so
I
you have
took
that.
up.
So you can see that. So you can see that depending on how much of your work you're giving to machines, your brain is
Yes.
going to start shrinking. Yeah.
Yeah.
So that is a very constant worry that we all have. And there are a lot of things that are being done to make sure that, we kind of guide the kids and the children or the younger age group people in the right path.
I think
I
to
know
give
it's a
more
pain.
creative work and constant, I think cognitive work would probably help to remember
Correct.
more things and read. I think the habit of reading, I think even a lot of old, I mean, my grandmother or even my wife's grandmother, and at this age also, they still keep reading and remembering things.
Correct.
So I think it's a
Very true.
continuous, yeah, so that they actually can,
Yeah.
be active.
That's
The
how the
brain is active.
yeah,
Yeah.
that's how the brain works, right? So the more and more you use the circuit, like I keep talking about the same thing, right? So you have a
Hmm.
circuit for memory, you have a circuit for learning. The more and more you use that, that area is going to become stronger. There is something called plasticity. So that's how the brain learns. There is a hypertrophy of that area, and your brain is active. That's why they keep saying solve Sudoku puzzles, do something
Hmm.
creative. You can
Right.
probably delay your dementia because of that. So if you don't do anything, just watch your mobile, watch non-specific reels, your focus is going to get become less. You are not able to really concentrate on one particular topic because you're jumping multiple topics in all the time, unlike you reading a good book and finishing it off. So that's
Right.
the difference that we see.
Yeah, I think that's also a distraction these days, right? It's not, the brain is also developing that way in terms of continuously. It is
Correct.
not able to give the attention because you've been
Yeah.
tuned from the childhood right now in terms of continuous moving from one to other in 20 seconds or
Correct.
just a minute. So it's a disaster where we are heading with the
I
technology.
know. I know.
Advancement is helping, but one other side, it is
It's
also having
yeah,
a con and
negative effect.
impact.
Yeah.
Yes.
Correct.
And you, just to summarize on the Parkinson question, right? I think so. So it is a so dopamine is the main, is a chemical messenger which is involved in many behavior, and that's if decreased production of that is going to have a prominent impact for the start of Parkinson's disease.
Absolutely.
Yeah, and then I think you talked about substantial Niagara. That's the
Yes.
black substance, which is actually where you
Maximum
probably
amount of dopamine is
maximum.
produced in the body.
Right, right. Okay. So my next question is on the continuing on the Parkinson. Um, how comparatively, right? How does the movement disorder, uh, I mean, impact the quality of life? And we talked about that. How can the families be supported, right? Do you think with the kind of population we have, do we have sufficient setup to actually tackle this kind of conditions along with the family? Because one is, while the patient is going through this and trying to get the treatment done, the amount of effort the family or the emotional trauma with the family goes through is also. So how do you
Correct.
think the
Yeah.
hospitals and the clinics are set up in terms of supporting that ongoing and in your practice?
Yeah. Yeah, so that's a very, very important thing, and I'm happy and proud to say that in India also we have a very, very robust support program for Parkinson's disease patients. We are part of more than two or three of such kind of
Hmm.
an organizations. Like you said, the Parkinson's disease also has a significant emotional component. Even though their memory is intact, like you said, the patient is doing fine, but is unable to do what he wants. So
Hmm.
his will is there, but his hands and legs are not cooperating. So that you can understand the kind of emotional impact that will have on a patient. So what happens then? The family also suffers because of that. So they get depressed. They are not able to communicate. They are not able to socialize with others because many of these patients who have severe tremors have this constant fear that when they meet new people or when they go to a
They
place which
get
is
judged.
crowded, they
Yeah.
will get
Yeah.
yeah, they will get more stuck and their tremors will become obvious and everybody will get to know. So we have a very, very robust Parkinson support group in which all the caregivers of the Parkinson's patients are there, including whether it may be the spouse, whether it may be the children, or any other family member who is taking care of these patients. And we're constantly guiding them and helping them to take the right decisions, go to the right kind of specialty doctors who can help them, and also physiotherapists and yoga guys. All of them are part of the support group because we know that if you do regular exercises, even after you get Parkinson's, you can definitely delay the progress of Parkinson's
Right.
because it's a progressive disorder. If you keep yourself active, you do yoga, you do walking, you do cycling, definitely I cannot say that the disease will get reversed, but at least you can slow down the progression of the disease. So there is a definite support group. Even now, the support group has a system in which even the medications, if sometimes some of them are expensive and they have to be taken for long, they're all being subsidized and given at a lower cost. So the whole concept of taking care of the family along with the patient is very, very active. And we even have a national body of Parkinson support group, which is very active in organizing meetings and raising awareness.
But do you see in I think in there were estimated 771,000 people living with Parkinson's over, and 45,000 deaths, because it's more of a research which I looked at from the WHO and also the Wikipedia. So meanwhile, how do you see this rise, and do you see how the first of all, awareness is one area which I know that from in India, even if you ask me like 10 years back, I probably wouldn't be thinking that Parkinson's is very prevalent in India, a country like India. But again, while it's a brain related neurodegenerative disease, but you don't have that awareness, right? But how do
Correct.
you think today, maybe because of the awareness and also a lot of tests, we are able to identify more patients. That's why the rise is.
Correct. Correct.
Or how do you see that in your practice, right? How many on a month do you think people come in probably, and then they probably in the initial stage of Parkinson's or probably it's progressed?
Yeah. So nowadays, definitely the awareness is improved. It's not reached a level where we can say very proudly that everybody is aware. From our side, like I told you, the support group side, we had a patient who underwent a DBS. He took it upon himself to raise awareness that this guy drove all the way from Bangalore right up to Kanyakumari. He went
Wow.
all along multiple cities and raised awareness. He used to conduct, he was part of a Lions Club or Rotary Club, I'm not sure, one of the two. And using their help, he used to go to small districts and raise awareness. So, what happens with many patients in Parkinson's in the initial phases? Usually, it's an elderly disease, right? It's about 60, 62, 65. So, they think it's just part of getting old. I've become slow, maybe because I'm old. I'm having shaking, maybe because I'm old. I'm having mild cognition issues because I'm getting old. So, everything they attribute to getting old. So, nowadays,
And
because
it's a
there is
very
a practice,
subjective term also. Sorry for interrupting.
exactly,
The
yeah,
old is also like whether nowadays even people think 60 is old and they're good. Okay, I'm done. Whatever.
yeah.
It's so.
No, exactly. So that's what's happening. So what has happened now in India is that the availability of doctors has significantly got better, right? If you see the south, at least I can confidently tell you, every small district has a neurologist. So that's like really amazing. When we started practice, everybody had to come to a big city to meet the specialist. Now the awareness has improved, the access to the specialist is much better. So that way, I would say that probably we are diagnosing a little more often than what we used to do 5 or 10 years back. So if you ask me in a month, coming newly diagnosed Parkinson's disease to a super specialist center, maybe 15 or 10 patients, but usually many of them are primarily diagnosed by their family physician itself and then
Hmm.
referred to us for further treatment. So that kind of an awareness is definitely improving. And like I told you, we are also trying through our support groups or organizing meeting ourselves where we go and speak to these people and kind of raise an awareness and say that please don't attribute everything to being old. Come back, go to your family physician, or first check up with your regular doctor. And if he's not able to solve it, go to a specialist and reach out to them.
True, true. I think again, constant awareness programs, especially for the families, right? And also the
Yeah,
patient, also for himself to be more self-aware in terms of what is the bodily changes, and then when we need to consult, general physician, and
correct.
also if there is a problem continually there, and then
Correct.
go to
So,
a
yeah, you
surgeon.
must
Yeah.
have read WHO has a World Parkinson's Day. So we try to make a big deal out of it. We have a walkathon or a program where we involve a lot of general public and tell them about the awareness. So that was the main idea of the WHO to have a day which was dedicated to Parkinson's, and all of us make it an effort to make sure that at least we are able to convey the message to the lay public about to identify Parkinson's early and take the right treatment.
So any specific, so I know that movement disorders is one. So being slow, you cannot just attribute always to the Parkinson's. Sometimes people are slow. Doing things slower, or probably movement. So it starts with movement. So the early signs, if you can actually just let audience know about at least an early
Yeah.
sign, when you really have to think about, okay, hey, maybe this is not just a issue with my joint or something which is happening in my body. Maybe I have to look at brain, something about Parkinson's or anything which is a neurodegenerative, right? So that's question.
Yeah. So the one of the most commonest thing obviously is to notice that you have a change of handwriting. Okay.
Mm.
So that is a very
Very
common
simple.
symptom that, yes, very, very
Mm.
early symptom. So you
Mm.
start feeling that your letters are becoming smaller.
Mm.
You are able to write nicely and big. And if you see, you write a line, you see your, I mean, I know it's a challenge now because many of you use computers. Even you're
Nobody writes.
signing a check. Exactly.
Okay.
So even if you're signing a check, okay, so you may have to sign sometimes. So if you do that and see that you are becoming smaller, the words are becoming smaller, or you feel there is a definite tremor. So that is one of the earliest sign. Other thing obviously is to notice any slowness, like you feel that probably you would be really doing things fast, getting up, walking out and all much before, but now even to get out of the bed or go out and do say 5,000 steps or even less than that, you are finding a challenge. You feel your feet is sticking to the ground. So all these are all early signs, which means that you need to come and see a doctor.
Hmm. Yeah, those are very, I think it's a good point, Doctor. Not many people will think about, this would probably something which I need to get it checked because it's very, um, probably, it's more of ignorance and also probably very small. And why would I spend time with
Correct.
the doctor? So that's the thought everybody has. Yeah. I think before we move to epilepsy, I wanted to get this. Can you explain? I mean, you did the India's first high cervical spinal cord stimulation case you
Yeah.
performed for Parkinson Plus on a 65-year-old patient from France. So I'm curious to understand, what was the complexity and how do you think that's a breakthrough for more patients to come
Yeah.
in, right?
Exactly. So, like I told you in the beginning itself, Naga, that we have this group of patients who mimic Parkinson's, called Parkinson's Plus, right? So, she was one of those candidates. She had what is called as Parkinson's Plus. So, she used to have repeated falls. She could not have control over her urine. She had to get up in the
Hmm.
night multiple times to go. So, these are all red flags for us, even when we are looking at patients with regular Parkinson's. So, when we see these red flags, we know this is Parkinson's Plus. So, this lady had all these features. She had what is called as anatomic disturbance. That means if you measure her BP standing up, it used to be a little okay. And if you measure her BP lying down, there used to be a significant difference.
Oh.
So these are all changes which we see in patients with Parkinson's plus. So this lady could not even walk with support. She needed at least 2 to 3 people support to walk. So usually we don't offer deep brain stimulation for such patients. So what we tried was what is called as high cervical spinal cord stimulation. That means I put an electrode near the neck. So that is the
Hmm.
cervical spinal cord. So what happens in that is there is this flow of electricity that is coming from the brain and that gets very concentrated near the upper part of the spinal cord and then goes down into the spinal cord to the rest of the body. So that is the area cervical spine, which has a lot of concentrated activity of electrical activity, which is going up and down the brain. So when we did this stimulation, what happened is all her hand movements became much more freer. Our gait became significantly better. Our urinary disturbance became significantly better. It's not like she became normal, but compared to what she was in a wheelchair, unable to move around. Now she's able to move around with one guy's support. Her urinary symptoms completely improved. So that was a kind of breakthrough. Is it something that is experimental? Definitely not. So there has been, like you were suggesting previously, there have been what is called as studies, anecdotal studies, where it is clearly established that when you stimulate the cervical spinal cord, the gait disturbance can get much better because we know that's how the movement is controlled. There is a lot of physiological and scientific background to doing that cervical spinal cord stimulation. So this lady had actually tried in all the pioneering centers in multiple places around the world. And when
Wow.
we came, we sat with the husband, and then had a very long discussion and had a realistic idea of what is he going to get from this stimulation, because it's very important, right? If patient has to undergo a surgery, they have to get convinced that it is going to get them better.
Right,
Okay.
right, true, very
So
true. Yeah.
we had a very realistic, honest chat with the family, and then we did the procedure. And to our luck or to her benefit, she had a tremendous response and she did really well. So we have done that even subsequently to other patients. And the advantage of spinal cord stimulation is we can do what is called as a trial. That means we put the electrode and check how the
Hmm.
response is. If the response is very good, then I put the permanent pacemaker. So that's what
Hmm.
we did with her, and she did really well. And we have presented it even in scientific meetings, and she's doing well.
So we have to, again, it's more of a minimally invasive in
Yeah,
these cervical to fix
very
that
minimally
electrode.
invasive.
Hmm.
Yeah, we make a small opening in the back of the neck and place the electrode. The electrode is about say 10 millimeter in width
Hmm.
and about 14 or 16 millimeter in length. So that's the kind of electrode, and we make a small opening and then push it through that.
It's wonderful. I think it's a life-changing moment for somebody who's
Yes.
been going through something of that sort. And I think especially anything with spine and neuro, it impacts your whole body
Yeah.
movement and your ability to talk, or anything which is more of a stroke or of that sort. It's a highly impactful time, and
Yeah.
I think these technologies actually reviving a lot of lives through that. I mean, kudos to you
Absolutely.
and the
Like I
team.
told you. Yeah, like I told you, even DBS for that matter is a really life-changing surgery. So we have done surgeries for patients who were surgeons who could not operate because their hands were shaking. They had to cut their practice off, saying that I won't be able to do it anymore. And we did the deep brain stimulation for them, and they're back to their full-fledged practice, including doing laparoscopic surgeries, which is much more advanced. So that's the kind of really life-changing things. We have young guys who thought, okay, my career is over, I can't work anymore. Now traveling all over the world, doing everything that they wanted to do, including doing gymming, playing active sports, they were able to play. So that is the kind of changing things that DBS does.
Yeah, I think I saw videos of after DBS, somebody's finished the complete triathlon and
Exactly.
won it too. Yeah. But so DBS again, it is more of a minimal. It's again a minimally invasive,
Yes,
very
yes,
focused, uh, surgery where you put the electrode in the brain, in the
correct.
specific part. Let's say if it's a dopamine or that substantial niagara, so where you place it and then
Yeah,
charge with.
yeah. The area is called the subthalamic nucleus or the globus pallidus centers. So that is very close to the substantia nigra. So these targets have been refined and found out over a period of time with multiple studies. So that is the area. Why is it called deep brain stimulation? The deep in the meaning DBS is because it's very deep seated. Yeah, and it is so specific. The STN nucleus is only about 5 by 6 into 12 millimeters, so it is as small as that. So you need to be extremely precise, and even in that subthalamic nucleus, I have to target an area which controls movement. So that's why the surgery is so advanced, and that's why it's so much dependent on an interaction between technology and the surgeon himself, so that you get an highly accurate results and good benefit to the patient.
And also, I understood that during the surgery, the important things to hear is the patient's voice, because the patient is active and talking during the
Exactly.
surgery, and
Exactly.
because it is not the area in the brain where your cognitive is impacted, so it is the movement. So you are continuously talking to the patient
Exactly.
throughout the surgery, right, and making sure that he's
Exactly. So it's a awake surgery. So imagine somebody drilling a hole into your head and putting electrodes into the brain, and it's so beautifully done that even if I touch your brain with the hand, or even if I cut your brain, you will have no pain. So God has designed it in a way that the center, which receives all the information, all the pain information from rest of the body, has no pain by itself. So that's like really amazing. So these are the few things that always excite me so much. So my patient is completely awake. We give him only local anesthesia in the head so that they don't have any pain over the skin, and there is a layer called the dura of the brain, which is the covering of the brain. These two structures are the only pain sensitive structures. So we anesthetize them, and then we do this whole procedure with the patient being awake, and he's also contributing. That means he tells me that my hand has become free, my hand has stopped shaking. So that way we get a confirmation that we are in the right place.
True. I think, and then during the surgery, you will hear all the brain neurons
Correct.
interactions throughout the
Correct.
surgery, right? I think there are some
Yes.
live videos in the YouTube too about the
Yes,
whole
please.
DBS, and it's amazing
Correct.
to look at
Yeah,
the kind
we,
of.
we record from yeah we record, like you said, the activity of the neurons. It's called microelectrode recording. So the electrodes are so fine that we can actually record from a single neuron.
Yeah, true. Okay, it's like goosebump moments. I think when you're doing it, I know it's how uh, mentally stable you have to be. So kudos to all the surgeons, right? I think.
Thank you.
So thank you, doctor, for all the information on Parkinson. So moving to epilepsy and functional neurosurgery, right? I want to move from more movement based to more of functional neurosurgery. What advancements has been made in treating drug-resistant epilepsy? Right, epilepsy, while it is a term which is known in the recent years, but usually in the past I've seen a lot of people who has that kind of a symptom, but maybe there is no active drug or probably treatment has been done. They continue throughout the life with that until their death. I've seen somebody having this seizures, but without, like, idiopathic, right, with no
Correct.
known reasons.
Correct.
So
Yeah.
just I want to know the advancements we've made
Yeah.
in.
So there's a lot of advancement now, Naga, to in terms of understanding the epilepsy. So there has been a significant leap now in terms of how we understand epilepsy from what we understood maybe say 10, 20 years back. So now we want to find a cause every time. And like you said, idiopathic, many times we don't find a cause. Okay, but we do what is called as a video EEG. That means the patient is hooked to these electrodes which are placed on the scalp, and we induce a seizure and then check in which activity area of the brain there is an abnormal activity. So to that extent, we are aware now where the electrical activity becomes abnormal. Then we have very, very good high resolution MRI scanners nowadays. The most commonly used scanners is what is called as a 3 Tesla, or the strength of the magnet is 3 Tesla. We even have 7 Tesla in some centers, which is for research centers. So in these, when you do imaging with these high resolution MRI with the very, very wonderfully designed algorithms and softwares, we are able to see very, very small abnormalities also in the brain. So that way we are able to identify what is the cause for the epilepsy in that particular patient. So once we identify the cause, then obviously we can try to treat that. So that is the whole idea that is happening in the field of treating epilepsy now, that to see and try and identify a particular area of the brain in which we can do. When do we call it drug resistant? If the patient is more than on 3 medicines and is still getting seizures, that is the time when we call them drug resistant. So there has been a significant advancement in identifying this drug resistant epilepsy first, and also in thinking of multiple therapies for their problems.
Yeah, that's, I mean, that's very heartwarming to hear, right? Because it's some of the patients are actually looking at some options like that to solve their, conditions, right? Maybe it's epilepsy or even just a seizures, which is there for a long for no reason. So this is a dual question which I want to combine it, right? So one is, again, DBS is a very, very major intervention here in epilepsy as well. And I mean, the story of, I want to get the young Yemen patient, you treated with Thalamic DBS. So maybe
Correct.
see how DBS is also helping on such.
Correct.
um,
Correct. So, yeah. So, like I told you, just to give you a background of what we do, is if we are able to identify the cause. Okay. So, when I say the cause, is that there is some abnormal architecture of the brain. That means the neurons in those areas are abnormal. Or I know that there is a degeneration in a very particular area of the brain. We now want to identify the abnormality in the brain either by using imaging, or we also have what is called as stereo EEG. That means in addition to putting electrodes on the scalp, we identify the area in the brain and we put an electrode inside the brain and check from where it is coming abnormal electrical activity. Okay. And then we try to treat or ablate or destroy that circuit. So it's the same phenomenon that is happening in movement disorder, but in a more generalized way in epilepsy. What is happening in epilepsy? There is a hyperfiring of all the neurons in the brain, and then that is leading to all these abnormal movements that is happening. Okay, so we want to modulate that. So we don't want it to spread to every area of the brain and induce an abnormal seizure movement. So this MNE patient, we did multiple studies like PET scan, like video EEG, MRI. We didn't find any abnormality anywhere, except for the fact that the electrical discharges were coming from one particular part and spreading to whole of the brain. Okay, so the idea is to suppress this abnormal electrical activity. So this fellow was a pharmacy student. So he was a very, very well-read, very educated kind of a kid. He wanted to get better very consciously. He had become very sleepy because of the excessive medicines that he had to take. His speech had become started to get affected because these medicines were having those side effects. So we counseled them. And thalamus is, we know now, is a very, very important area of the brain which generates this abnormal electrical current spreading to other areas of the brain. So that's why we did the centromedian thalamic DBS. So after we did that, now it's 3 months. He has done really well. His cognition, his speech has improved. He has become more alert. He's able to go back to his college and do all the activities that he thought he could never do. Obviously, we have not come down on the medicine significantly right now, just 3 months now. So over a period of time, we anticipate that that also will get better.
This happened in May, right? In
Yes, yes,
2025. So
yeah,
which is not too old. So it's an
correct, correct.
amazing news to hear
Yeah,
yeah. I think it's one of a
because
kind in Bangalore.
exactly, not many centers are doing this centromedian DBS in whole of the country. So we did that, and Nimans has just started doing it. So we are really happy and very good for the patient that after the surgery he never had any episodes, which is a big difference for the patient.
So do you see more patients are actually probably at least we're able to identify after this? You're
Exactly.
able to in the last three
Yeah.
months. You've seen the turnaround or more.
Not really. We've always been seeing them, but like I told you, if there is a reason, there is something called a resective surgery. That means we resect the area of the brain which is abnormal. Sometimes, if it is too spreading too much, we do what is called as a destructive, surgery. That means there is a connection between the two halves of the brain. We try and disconnect one half from the other half so that the electrical activity does not spread. That is called hemispherotomy. So, like that, there are many surgeries. There is something called temporal lobe, which is the most commonest area for producing seizures. Sometimes patient develop sclerosis or degeneration in that area. So we just remove that abnormal or degenerated area, which is called as temporal lobectomy. So these are the commonest things that we do. So there are multiple options for patients. And in patients, we don't find any reason and still having hyper electrical activity. That's why when we consider deep brain stimulation.
Got it. Yeah, I mean it's not that again it has its own risk any surgery
Correct.
for that matter. So it's not everybody can go through it. Again, physically you need to be also fit
Correct.
to have that. Other than this complexities. Um, so I mean we talked about more of this non-cognitive or probably non-functional neurodegenerative diseases. But when do you think the functional conditions actually require a surgery? Right? What are the cases in which you have recommended or you've done patients where they're having a functional degeneration in the brain, and then it needed a surgery? So what kind of uh,
So you're talking about epilepsy or generally functional conditions?
generally function?
Yeah. So there are two things, right? Yeah.
Go ahead.
We have to differentiate what is a functional condition from what is called as an organic condition. So that's how we classify in medicine. Okay, when I say functional, it means there is no organic cause to that. That means patient may be just stressed out or maybe anxious and they're having this kind of attacks, which is like epilepsy, which is not like a true epilepsy. That means when I do an EEG or electrode recording from the brain, that will remain normal. Okay, so this is when I'm doing what is called as video EEG. That means I put the patient under my camera, monitor them 24 hours, and when they have these episodes, I don't see any change in the brain. Okay, so that is like a functional epileptic condition. For that, there is no surgical intervention required. Only if it is an organic cause, there is a definitive abnormality in the EEG, there is hyperelectrical activity, then only you need a DJ intervention.
Okay. So any functional neurological disorder, functional seizure or tremor or, um, dystonia or anything which is more
No,
just a
I think I want to clarify that, Naga.
facial spasm or, I mean,
Yes. So
I've noted down few of the important functional disorders, which again, like
no,
stroke.
that is not called functional disorder. I think you're confusing. I'll just clarify your doubt for that.
Okay.
That is not called functional disorder. Okay. There is a
Okay.
difference between functional neurosurgery and functional disorders. Okay. Functional neurosurgery, why is it called functional neurosurgery? Is for the fact that improve the function of the patient. Okay. So that is very different. So don't get confused with dystonia is an organic condition. That means that it's not a
Again,
functional
it's
disorder
not a
at all.
functional. Okay.
It's not a
Right.
functional disorder. Tremors is an organic condition. It's not a functional
It's not
disorder
a
at all.
functional disorder. Yeah.
Exactly. Functional neurosurgery treats these patients. Why is it called functional neurosurgery? Is because we have to improve their function. Okay, so that is the challenge in functional neurosurgery. Like when you join neurosurgery, when I joined neurosurgery, a lot of my colleagues and peers and seniors told me, Raghu, why do you want to join this specialty? Everybody will be paralyzed, everybody will be bedridden, everybody will be lying in the bed. What are you achieving? You'll never get job satisfaction. Whereas in functional neurosurgery, never the case. We are always there to improve the condition. So you can't do anything in functional neurosurgery which will make the patient's function down. So that is the challenge, and that is the skill and the effort that you need to make sure that this dystonia patients or tremor patients get better. So that is what is functional neurosurgery.
Got it. Got it. So the uh, seizures or tremors, dystonia is more of, you're saying it's an organic condition.
Correct.
Again, to get them better. So the neurosurgery is more of functional neurosurgery is to
Is a branch of neurosurgery. Yes, it's the branch of neurosurgery which deals with these conditions.
right. Got it. Um, okay. I think we talked a lot on DBS and epilepsy. So my last question on epilepsy is again the same problem we see in terms of the awareness, but how do you think like Fortis probably is one of the plays? There are a lot of innovations and research is happening on this area, but how does it available for common people? And let's say if somebody wants to go into, how do you think the technology advancements are actually spreading across different hospitals, and how they are adopting it? Is it you see that there is a policies coming in terms of using these in a I mean the cost factor as well, it's not like very easy to for a common person to adopt it, right? So I want to get your perspective on that.
So right now there is definitely a very robust program even in the government sector about epilepsy. If you take at least the flag bearer institutions like NIMANS or Sri Chitra or the AIMS Delhi does really a lot of pioneering works in epilepsy. So in terms of accessibility to this healthcare, yes, we need to get better compared to what it is in the West. Definitely, there is a huge scope for improvement, but it is definitely accessible. The technology that I use in Fortis or any other corporate hospital in India is definitely available in many government centers all across India right now. So that way, we are really at par with many centers in the world. The population size is so huge and the disease burden is so much that obviously we can't do or perform as well as the Westerners can do. So definitely there's that gap between the everybody having access to few of them having access, and we are trying constantly to bridge that. Even two-tier cities have good neurosurgeons, epilepsy surgeries now. So that way, also in our meetings, have constantly been having workshops. We have hands-on cadaveric workshops where we train the young neurosurgeons on all these newer technologies and newer procedures. So in their practice in their cities.
Got it. For everybody, right? Because it's an important sleep is the number one priority for everybody, but especially for children, in the growing stage. So you can't
Absolutely.
compromise.
Absolutely, Naga. I think that is the most important thing that we are talking about today. I think there is so much research on the scientific evidence on the fact that you should have a proper sleep. There is no doubt. It will help you in improving your heart function. It will help you in improving your insulin level of resistance, help in liver, kidney, brain, everything. So there is no doubt that lack of sleep or irregular sleep or sleep. So there is no doubt. See, that's the whole idea, right? All our goal is to make the patient quality of life better and get better results. So I think there is nothing saying that you should not accept these technologies. The commonest word that you use now after COVID is called brain fog, right? So you tend to develop brain fog. So it is all known. So now, if you're asking me about youngsters, especially people who are there, say 25, 26, they're all aware. I mean, I know that the younger generation eats a lot of junk and high sugar food. Maybe we are aping the West in terms of doing that. If you go to a mall on a Saturday or a Sunday and just visit the food court, you'll say that okay, all
Amazing.
the doctors are
Yes.
good.
Over technology you use, but still there is an emotional angle to it, which is important, especially in the field of medicine.
Yes, and there are a lot of ethics involved, right? So obviously,
it's true, very true.
Yeah, you can't expect that from a machine. So obviously, emotion and ethics and the empathy that you see will always have to come from another human being the doctor.
What is one misconception you would like to correct about brain surgery or neurological illness?
Yeah, the most important misconception is the fact that once you have a brain condition, that's the end of your world. It is going to progress. There is no treatment for it. That is the commonest misconception. Even for spine, many people think that you touch the spine and do any surgery, you will become paralyzed. So that is no longer true. We have so much of advancement in terms of infrastructure. We have things which are called navigation. That means these equipment guide us to the area of the tumor very, very safely, and we can completely remove the tumors because of these machines and other artificial intelligence things that these guys help us with. The biomedical engineers help us with. So please do not worry if you have a medical condition involving the brain.
If you found this thought-provoking, please don't forget to subscribe and explore more insights from unfiltered voices and the real-world experts. And please don't forget to like and share this video to as many people as possible. It keeps us going. See you in the next one.